Good evening, everyone. So we are starting our thyroid clinics today. Today is the first thyroid clinic we are starting. And I welcome our patrons, Professor R.V. Jayakumar sir and Professor Prasanna Kumar sir. And we have started this thyroid clinic under the guidance of Professor Sarita Bajaj ma'am. And I think ma'am got logged out. Ma'am got logged out, I think. So Professor Sarita, ma'am has logged in?
No, she just got logged out, ma'am.
Yeah, so in the meantime, we can just start, I think. So ma'am has got logged out. She'll be joining soon. So the thing is, the flow will be like that we have two cases. One is a long case and one is a short case. So first we'll have the long case. After the long case, we'll have a very interesting quiz. And I request everybody, all the audience, to please take active participation in the quiz because there are prizes to be won. The prizes are first, second, and third. And they will be given a certificate which will be sent to them. The certificate will be given by the Indian Thyroid Society. So it will be a nice thing if a lot of people participate. And I also request all the residents who have joined to please participate in the quiz actively. And once the quiz starts, we'll let you know before that how to put in your answers. So you have to just put your answers in the chat box and we'll tell you how to do that before we start the quiz. So quiz will be done after the first case is over. So please be there. Don't think that the quiz will be after, because in that we have written the quiz as third, but quiz will be in between. So please stay there. And I would, I don't think Professor Sarita Bajaj ma'am has been able to join back again. So I request Professor Nilanjan to please start with the proceedings, and we can start with the first case. Once ma'am joins, she will give us a brief overview of the thing.
Thank you very much. At the outset, I express my heartfelt thanks to the Indian Thyroid Society, headed now by the very dynamic Professor Sarita Bajaj, for conceiving such sort of thyroid clinics and giving us the privilege, that is the Department of Endocrinology, NRS Medical College, Kolkata, the privilege to be an active participant in the maiden session. And for the residents, I think there would be a lot of interactive learning, and learning with fun also, because there would be a quiz which is always has its own inherent interest. And I once again thank the entire team who has been instrumental in putting forward this show, this event. And I think without further ado, we can straight away go to the long case under the moderation of the chairperson for that session. Over to the moderator, sir. I think Professor Prasanna Kumar would be moderating this session. Over to you, sir.
Unmute. Dr. Prasanna, unmute yourself.
Thank you, Dr. Nilanjan. Good evening, everybody. Welcome for this case presentation. Before that, now we have Dr. Sarita Bajaj. I wanted to give a small talk about the concept of this, the master clinic. Over to Dr. Sarita.
Yeah, thank you. Thank you. Good evening, everyone. I'm sorry for the initial hitch here. And of course, thank you, Dr. Prasanna. I'm very passionate about knowledge sharing and education. When I took over as the president, this passion became thyrocentric. And the question was how to organize a continuous learning program which would be of help, which would address the need of clinicians, trainees, and experts alike. So therein, we thought of this weekly program involving institutes where DNB and DM programs are being organized. The second agenda was to create awareness about our flagship journal, that is Thyroid Research and Practice, which has a very short turnaround. The third agenda was to increase the membership of the Indian Thyroid Society. And we have a wonderful team. We have our very supportive patrons, Dr. R.V. Jayakumar, who is the founder president of the Indian Thyroid Society, and Dr. Prasanna Kumar, whom I admire greatly. I think he's no less than a legend as far as contribution to science and endocrinology is concerned. We have Dr. Pramila Kalra, who's been the backbone. She's the scientific chair, constant support of Dr. Minnie Pillai, Dr. Arun Menon, then the entire EC, Dr. Rajesh Rashford, Shashank Joshi, Dr. Hema Girish Rao, Dr. Krishna Seshadri, Dr. Sujoy Ghosh, Dr. P.K. Jabbar, and of course, not to forget Dr. Nilanjan Sen from the Host Institute, who has been amazing. The minute I spoke to him, he said, "Yes, we'll go ahead. Thank you so much, Nilanjan." And of course, we have with us Dr. Deep Datta as well, who is organizing the quiz. Thank you very much. Over to you, Pramila.
Thank you, Dr. Sarita Bajaj. Now we'll start the case discussion. The flow is like this. Now this case will be presented by Dr. Yashasvi Pathak from Kolkata. She will present the case, and I request everybody, if you have any questions or comment, you can put it in the chat box, and the faculty are here, can interpret and then ask a question so that the flow continues. So even if you want at the beginning or in the middle, you can interpret and then say, what is your opinion? That's how the case discussion will go. And it's my pleasure to invite Dr. Yashasvi Pathak to present the case.
Thank you, sir. Thank you so much. I'd also like to thank Indian Thyroid Society for this very important session, especially for us residents under the expert aegis of Dr. Sarita Bajaj ma'am. The first case for today is Graves' disease with thyroid-associated orbitopathy. Sorry, just hanging. So the patient, Mr. Ashok Singh, 48 years of age, resident of Howrah district, a tailor by occupation, presented to our clinic with complaints of protrusion and redness of both eyes for last 1 year and diplopia for last 7 months. History of presenting illness. Patient was already a known case of thyroid disorder for last 4 years and was admitted with complaints of protrusion of right eye around 1 year back, which was followed by protrusion of left eye 1 month later. It was insidious in onset in both eyes and was associated with grittiness and foreign body sensation in both eyes. It was also associated with redness in both eyes. It started at around the same time and also swelling around the eyes. Patient also complained of pain in eyes on movement, but not at rest, and it was associated with excessive watering from both eyes. Initially, patient did not complain of diminution of vision, but for last 1 month, patient has noticed some decrease in distant vision, but not in near vision. There's no history of impairment of color vision and no history of ptosis. Patient also complains of diplopia for last 7 months, insidious in onset. Initially, it was intermittent, present mostly during morning hours, but now has become constant. Diplopia is more on looking laterally and improves on closing one eye. There's deviation of right eye inwards and upwards for last 1 month with difficulty in lateral gaze. Patient was diagnosed as a case of hyperthyroidism 4 years back when he presented with complaints of tremors in both hands, palpitation on exertion, and increased sweating. Patient also gives history of weight loss, which was subjective, as patient did not check his weight but complained of loosening of clothes, and it was associated with increased appetite. History of heat intolerance was also present. There was no history of increased stool frequency, neck swelling, dysphagia or dysphonia, no history of hypo or hyperpigmentation of skin, no history of swelling or redness over legs, postural dizziness, muscle weakness, bone pain or fractures, gynecomastia or erectile dysfunction. There was no history of jaundice, dyspnea, fever or pedal edema. The treatment history was that at diagnosis, that is when the patient was diagnosed as a case of hyperthyroidism, patient was started on tablet Carbamazole 20 milligrams thrice a day. After starting treatment, symptoms gradually improved. Patient initially underwent regular thyroid function test monitoring once every 6 months, and the dose was gradually brought down to 30 milligrams per day in divided doses. However, following this, patient did not get thyroid function tests for a year, but continued to take 30 milligrams of Carbamazole. Patient then developed ocular symptoms and was referred to our hospital. Patient was first admitted in July of 2021 and has since received a full course of IV methylprednisolone in the form of 500 milligram weekly doses for 6 weeks, followed by 250 milligram weekly doses for next 6 weeks. However, 1 month after this, ocular symptoms did not improve and there was slight worsening of distant vision. Patient was then given high-dose pulse methylprednisolone in the form of 500 milligrams per day for 3 consecutive days. There was some improvement in diplopia as the patient told. However, patient still had clinically active disease and patient was then given injection rituximab 1000 milligram 2 doses 14 days apart. 1 month after the last dose, redness and swelling of eyes is improved. However, there was no worsening of vision. With regard to treatment for hyperthyroidism, patient is currently on tablet Carbamazole 10 milligrams once a day. Patient is not a known case of diabetes or hypertension or any other chronic illness. Personal history complains of decreased sleep, appetite is normal, bowel and bladder habits are normal, and patient is not a smoker. There is no history of similar complaints in the family. Coming to examination, general examination, pulse rate was 88 beats per minute, regular, normal in volume, no pulse deficit. Blood pressure was 120 by 80 millimeters of mercury, right arm supine position. Height 163 centimeters, weight 69 kgs, and BMI 25.9 kg per meter square. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. Hands, an examination of hands, there was no tremor. The hands were not warm or moist, and there was no onycholysis. No thickening or redness of skin over shins, and there was no vitiligo or hyperpigmentation anywhere else in the body. Thyroid examination, patient has a goiter grade 1B, uniform enlargement with smooth surface with no nodularity. There was no tenderness. The lower border was palpable. There was no bruit and no lymph nodes were palpable. The eye examination, the picture of the eye is present on the upper right hand corner. Patient had conjunctival swelling in both eyes, lid swelling in the right eye, not in the left. Conjunctival redness was present in both eyes. Lid redness was not there. Pain on gaze was present in both the eyes. So clinical activity score in the right eye was 4/7 and in the left eye was 3/7. Exophthalmos as evaluated by Hertel's exophthalmometer was 21 millimeter in the right eye and 22 millimeter in the left eye. Visual acuity was 6/24 and 6/9 for distant vision. Near vision was normal. Lid retraction was seen in the lower lid of the left eye was 3 millimeters. The right eye lid retraction could not be assessed because the patient's eye was already deviated. There is restriction of eye movement in both eyes. In the right eye, there was restriction of movement laterally and downwards, indicating involvement of medial rectus and superior rectus. And in the left eye, there was the restriction of movement in the outward direction, again indicating just involvement of medial rectus. Lid lag was present. There was no lag of ophthalmos. Pupils were bilaterally symmetrical and reactive. Color vision was normal and confrontation test was also normal. Systemic examination was within normal limits. This brings me to the end of my history and examination. So shall I proceed or?
No, let us see if there are any questions from the faculty or audience, whether audience have put any question. Now, here is a question from Dr. Surendra Gupta from GAMS, Ludhiana. A stable case developed exophthalmos despite higher 30 milligram dose of neomercazole is a question in itself. Now, what will you react to this?
So one likely reason for it could be that, as I mentioned, the patient was initially undergoing regular thyroid function tests, and on testing, patient was being found to have normal thyroid function tests, so his dose was being gradually brought down. However, for a period of 1 year, and especially that was during the COVID lockdown, that is when he did not get any thyroid function test done, but he continued with the same dose. So the patient could, since he did not get tested, patient could have developed hypothyroidism also, because initially the dose requirement was decreasing. So that could be a reason, since hypothyroidism can also be a reason for precipitation of thyroid associated ophthalmopathy.
Can Yashashvi, can we have thyroid function test at the time when patient deteriorated? What was the TFT?
Yes, sir. Sir, it is there, sir. Sir, shall I go on to the investigations? Sir, I have mentioned it in the investigations.
No, if whether people have, before diagnosis, whether people have any questions on the history taking at all or the course of the disease. Like you have already come to treatment. You have already said what was the treatment taken. I will ask
Yes.
the faculty, how many of you use 30 milligrams twice a day anti-thyroid drug? Has anybody used that dose? Is that the dose that is advised? Because I don't know, my experience, I have never used more than 40 milligrams. And does it make a difference, Dr. Yashaswini, whether you see, there are two types of people. Some people start a large dose, come down like this 10 milligram. Some people start small dose. And second thing is whether you give 10 milligram, 20 or 30, once a day, twice a day, thrice a day, does it make any difference? I want to know from you.
Sir, with regard to dividing up the doses of carbamazole, sir, it has been suggested when the patient comes with features of frank hyperthyroidism, initially it can be given in divided doses to increase the effect. It has been seen in some cases. However, a single once a day dosing of carbamazole is also effective. And also, sir, with regard to the maximum dose, sir, a carbamazole dose of more than 60 has not been found to increase the effect of carbamazole. Like generally the maximum dose till which the effect increases is 60 milligrams. Sir. That is generally what we give maximum dose of 60, 40 to 60.
I think we only give only 40 because studies have shown that even online studies have more than 40, the effect plateaus off. That is my personal view also. 40 is enough.
Prasanna sir, you are muted. You are muted, sir. You have to unmute yourself.
I agree with Dr. Jay Kumar. I have never used more than 40 milligrams last 3 to 4 decades. And it does not matter whether you use 30 or 40 or 60, not that effective. Second thing is, though the half-life of the carbamazole is 4.5 hours, half-life is 4.5 hours, the effective life is 24 hours. So it does not make any difference. A lot of physicians use 10 milligrams 2 times, 3 times, but there are a lot of studies, not today, 30 years back, to see single dose 30 mg versus 10 mg 3 times. It really does not make any difference. Time taken for that to come down is safe. So two groups of people, start with 10 mg, increase it to 20, 30, whatever it is, single dose. Other thing is use a large dose and then come down like this. But the outcome of the disease does not vary. But if you use larger dose, patients become euthyroid earlier. That's all what the whole thing is. So the dosing, maximum dose, minimum dose, starting high dose, coming low dose, or starting low dose, going to high dose. So anything is all right depending on that. But if you understand the pharmacodynamics, pharmacokinetics, and the effective life of a drug, then you realize. Same thing about methymazole also. There's no difference. Whether you use carbamazole or methymazole, that the difference does not make, and it is the same. These are some of the things, because you may get confused that people may run away with the impression I should start 60 milligrams, but I've never used 60 milligrams. And yes, you want to say something?
Yes. Actually, I agree. Even if we see some recommendation based on body weight, even if you calculate the total dose of carbamazole or methymazole as per body weight also, going beyond 40 milligram does not make much of the difference. Coming to whether we give OD, BD or TDS, one has to remember it is not plasma concentration of the drug. It is intrathyroidal concentration of the drug, which is more important. And it has been shown that the drug is concentrated 16 times higher as compared to plasma levels of carbamazole. That is why it does not make any sense giving it twice or thrice a day. Having said this, there is one exception to this rule. And that exception is when patient is having severe hyperthyroidism, and that too when we have done technetium per technete scan, where it shows that gland is even not retaining your radioactive. It means it is throwing out everything very fast. Those are very rare cases where we need actually to split the dose so that at least some dose should retain inside the thyroid gland. But these are very few cases. For general message, we should give it as an OD dose. And lastly, comparing methymazole versus carbamazole, one is a prodrug, one is an active drug. Methymazole is an active drug. So if you see the conversion, 10 milligram of carbimazole is equivalent to 6 milligram of methymazole. So this conversion, one must also remember when we are using the two drugs which are now both available in our country. So these are some of the important points in therapeutics, which on the historical aspect, we must show why we are using. And I agree, we see daily lots of patients who are referred to us who are already receiving 20 milligram or even 30 milligram twice or thrice a day, and nothing is going to making a difference. And even when we reduce the dose, patient remains same, or sometimes even patient improves. So these are some of my opinions regarding this case.
Thank you very much. I think every point that he said is very, very important, because there is a lot of difference between what you read in a textbook and your clinical experience and what the research shows. So combining all these things plus the guidelines. After all, guidelines is the ones what we see depending upon evidence-based medicine. So everything should be dependent on guidelines, but even the practical experience after treating 10, 20, 30 years, you become wiser, you develop your own method, and that's what. There's a question, I think we should answer this before Dr. Yashaswini goes back to diagnose and all. This question is again from Dr. Surinder Gupta from Ludhiana. Neomercazole treatment, how much, how long? Can it be toxic if taken for long? 2 years is the accepted time for hyperthyroidism treatment, but some endocrinologists prefer small preventive vaccine type 5 milligram for 5 years. So before we go on, I want Dr. Yashaswini's comment on this question.
Yes, sir. Sir, with regard to the duration of treatment, so generally, sir, the duration of treatment is 18 to 24 months. And before stopping treatment, we generally, sir, should go for TSH receptor antibody tests. So if they are negative, then the likelihood of the patient being in remission after stopping the drug is high. So we can stop the drug. However, if the TSH receptor antibodies are high, the likelihood of patient being in remission after stopping is low. So some experts have suggested, sir, to continue with a low dose of 5 to 10 milligrams over a longer period if the patient has high TSH receptor antibodies, even at the end of 24 months of treatment.
Good answer, but I want one question. Suppose cost is not a factor or facility, will you do anti-TSH receptor antibody at the beginning of?
Sir, so at the beginning
Sorry,
of
now I muted, sorry, yeah. Can you hear me?
Yes, sir. Yes, sir. I heard your question, sir. So, with regard to, sir, testing for TSH receptor antibodies at the beginning of treatment, sir, for, sir, helping in diagnosis, if a patient like ours, sir, if the patient has clear-cut features of hyperthyroidism along with ophthalmopathy, so then the diagnosis of Graves is almost confirmed. So, sir, in such cases, TSH receptor antibodies do not help us in diagnosing the patient as Graves. However, sir, even sir, at initial diagnosis, sir, TSH receptor antibodies, sir, can help in predicting if the patient will go into remission with anti-thyroid drugs.
I actually help Yashaswi. See, if you go by guidelines, she is partly right. TSH receptor antibody should be done in every patient. But ideally, in real world setting, because of the cost involved in it, and because it is not freely available everywhere, we does not advise TSH receptor antibody in every patient. There are some other predictors also, like size of the thyroid gland, whether patient is a smoker, gender of the patient, so the ratio of T3, T4 ratio. There are research papers for each and everything. So basically, if patient has got a baseline TSH receptor, then only we should repeat it to predict the outcome. But largely, it is echoing. It is echoing. But largely, Dr. Prasanna will agree with us. Whatever research, whatever literature you will see, in best possible ways, the remission rate is only 40%, maximum up to some studies 45-50%. And that is why few of the experts in the world as well as endocrinologists in our country believes that giving 5 milligram a dose is not going to harm that patient. So that is why once patient achieve euthyroidism, they reduce the dose. and continue the patient on that 5 milligram dose. If somebody wants to stop it, he can definitely stop it, because majority of the remissions, relapses happens within first 3 to 6 months. If they are not happening, we can wait and watch. But once patient relapses after one such endeavor, then probably it is for certain all such patient needs lifelong therapy.
Thank you, Doctor. I think it's a very important point. Doing anti-TSH receptor at the beginning is not going to help or predict even remission. As Dr. Yashaswini said, maybe when you want to stop, what is your guidelines to say? If the patient is on 5 to 10 milligram euthyroid, it will help. One. Second thing is, if anti-TSH receptor antibody negative, again, it's not 100%. Remember that. That's all what. If somebody is already on 30 milligram, is still thyrotoxic, you don't need any test at all. Definitely, he is not going to get into remission if you stop. That is the thing. Regarding the duration, in the last 3 decades, a lot of papers said, as Dr. Yashaswini said, 18 to 24 months. Now there is a recent data. If you give them for 30 or even little more than that, there may be slight increase. Instead of 40, it may be 45. It's not 80% or anything. So my own thing is, if somebody does not respond, even at the end of 2 to 2.5 years, continuing beyond 3 years or anything, the chance of remission is poor. But these are few papers which showed you can go up to 2.5 years or even 3 years. Some people have gone to 5 years and all. So that is the thing. There is one more question. I think there are a lot of questions coming. It is unfair if we don't ask that this one. Dr. Manpreet Sethi asks, can Graves' ophthalmopathy be unilateral? Dr. Yashaswini, you can answer this. Can it be unilateral? Dr. Yashaswini, are you there?
Sorry, sir, I forgot to mute myself. So sorry.
Yeah, okay.
Sir, it can be unilateral. It has been seen in up to 10% of the patients. It is unilateral, or it can be asymmetrical, starting with one which appears that the patient has unilateral but may develop in the other eye later on. So that can appear as a unilateral proptosis, later developing as bilateral.
And in this case also same thing happened. It started one side, and even now if you see that the left eye is not so bad compared to the right one. So it starts unilateral, maybe bilateral, but many times you see unilateral. But if you have other unilateral, you should also think of other causes. Again, a question from Dr. Shruti B, that how smoking exacerbates ophthalmopathy. Tobacco chewing also, can it exacerbate? What's your answer?
Sir, smoking, sir, exacerbates Graves' ophthalmopathy, sir. The smoking extracts, cigarette smoking extracts can reach the orbits, either through the vascular system, but also it has been seen that through the paranasal sinuses also, sir, there is an effect of these. So, sir, the effect of cigarette smoking has seen to be significantly more on thyroid-associated ophthalmopathy as compared to tobacco chewers. And so the mechanism is, sir, there is increase in reactive oxygen species. Also, there is increase in hypoxia inducible factor 1, and sir, increase in IL-1. All of these, sir, act on through the cytokines, sir, act on the orbital myofibroblast, causing differentiation, increase in fibroblast proliferation, and also their differentiation of myofibroblast into adipocytes, increasing adipogenesis and the synthesis of glycosaminoglycans.
Thank you. There are two more quick questions. I think you should answer this from Dr. Surinder Gupta, Ludhiana. Are non-responsive hyperthyroidism cases with ocular symptoms an eligible case for radioactive iodine? Any contraindication? Question number one. The second thing is, same delegate has asked another question. So the question is, just a minute. Hyperthyroidism cases end up in hypothyroidism later in life. Any guidelines on follow investigation? Two questions you can answer together.
Sir, with regard to, sir, radioactive iodine, sir, in case of patient with in case of a patient with inactive eye disease, we can give radioactive iodine. However, in case of patients with active eye disease, It can be given if the patient is not responding to other treatments and patient is hyperthyroid, but it should be given under a cover of oral corticosteroids, higher doses of 0.3 to 0.5 milligram per kg in high risk patients like those who are active smokers, very severe active eye disease, and a lower dose if the activity is less, like 0.3 to 0.5 mg per kg of prednisolone, if the activity is low and the patient is non-smoker and other risk factors are less.
Thank you very much. There is one last question before you complete your presentation, because there are another 5 minutes. Dr. Shruti has asked, is there entity where Graves involving one lobe of thyroid?
So Graves involving one lobe, sir. As far as I know, sir, Graves is a diffuse disease because of, what do you mean? I'm not aware of.
Let us say hypothetically a patient has got only one lobe of the thyroid, other agenesis. They can also develop Graves' disease, isn't it? So it is not something which is unheard of, though we have not seen such cases. Right from birth, somebody has got one lobe, other lobe is not there. So if they get it slow, I mean, theoretically it is still possible. So you can go ahead with your diagnosis and complete the case. At the end, I want you to tell me, why did you choose this case? Let us say we have got 135 people. That itself is an indication that Dr. Sarita and Dr. Premila, that this masterclass is very useful. People are interested, Dr. Nilanjan, and these are all very interesting cases. I think we should follow the fact that 135 people are there. Maybe many more will join. And lastly, I will ask Dr. Yashaswini to complete the case.
Thank you, sir. So coming to the diagnosis, patient is a case of Graves' disease with thyroid associated ophthalmopathy, clinically active disease with a clinical activity score of 4/7 in the right eye and 3/7 in the left eye, with moderate to severe disease in terms of severity. Currently euthyroid without clinically euthyroid without dermopathy and without acropathy. So coming to the investigations, sir, the relevant investigations, there was nothing significant. The patient was not a diabetic, as evidenced by his fasting plasma glucose 96. PP was slightly increased, 142, and HbA1c was 5.6. So lipid profile, cholesterol 205, triglycerides 234, HDL 64, LDL 94. Viral markers were negative, and fundoscopy was also normal. Thyroid function tests. This is a timeline of his thyroid function tests. The first test that we see here is the one that was at diagnosis. TSH was less than 0.01. This patient was diagnosed outside and came to us only when he developed ophthalmopathy. TSH was 0.01. Total T4 was more than 30 micrograms per deciliter. Total T3 was more than 800 nanograms per dl. Then the patient was following up. However, he did not have those records. When he developed ophthalmopathy, that time his tests were done. TSH was elevated, 12.4 micro international units per ml, FT4 0.9 nanogram per dl. After that, the patient's dose was decreased and patient was being followed up. And since then, patient has been clinically euthyroid and currently on 10 milligrams of carbamazole. Patient's TSH was 1.2, FT4 was 1.2, and total T3 was also known. This is an image of his CT orbit, which was done, which shows that the right superior rectus was markedly enlarged and the medial rectus was also thickened. And also, even on the left eye also, there was slight thickening of the medial rectus. So this brings me to an end of my presentation. Thank you. And I would also like to thank Professor Nilanjan Sengupta for his guidance for this.
Thank you, Dr. Yashaswini. I think we are almost there. Can you give me one sentence why you have presented this case? No? Ultimately, you have to justify, is it a diagnosis problem? Is it management problem? Or is it a rare case? So suppose somebody asks, why did you choose this case for presentation?
Sir, presentations are one of the reasons was, like this patient, most of the patients develop ophthalmopathy within first year of diagnosis or at the time of diagnosis. This patient developed ophthalmopathy as a result of developing hypothyroidism. So this was one reason. Also, sir, the presentation of the patient when he came, sir, The treatments, there was a treatment difficulty because we gave patient a full course of methylprednisolone. However, there was not improvement in his clinical activity. So we had to resort to second line treatment. We had to go for rituximab. And also, sir, when we look at his eye, sir, there is a little bit of a difference in what the general presentation is. So generally the inferior rectus is the one that is most commonly involved. However, in this patient, we can see that the superior rectus is the one that has been involved. It's sparing the inferior rectus. So while it is seen that inferior rectus is most commonly involved, it is not always the case. So sir, these are a few reasons because of which this was a little different from the usual cases that we see.
And yes, another thing I observe, let us say people who don't respond to steroid, do they respond to rivaroxaban? Because a lot of studies have shown it is no better than the other. There are some people who say, but our experience with this is very limited unless somebody wants to share. Yes, Dr. Rajesh?
I have just one comment. See, when your patient presented to you, his TSH is already 12. And some 15 years back in Postgraduate Medical Journal, we have published hypothyroid associated orbitopathy. Now, if this patient dose has been reduced with the steroid which you have given, probably over next 3 months, patient might have improved on its own, saying that rituximab actually has made some difference. I have my reservations because in such type of cases, saying if we see rituximab studies, what Dr. Prasanna is asking, there is an Italian group, there is an American group. Both the studies have shown different results, and that is why Cochrane meta-analysis currently do not recommend it to be a treatment of choice for thyroid-associated ophthalmopathy. If we have to use, we have more experience. Personally, I have more experience using cyclosporine along with methylprednisolone in those group of patients where patients are not responding. And in NEGM study, it has been reported that combination of methylpred plus cyclosporine scores over use of either of these drugs alone. So these are some of my observations that at that point of time, this patient was actually subclinical hypothyroid. So just waiting for some more period of time, disease might have come into control on its own.
Thank
Number
you.
two, total dose of methylpred, which is currently recommended in literature, is 4.5 grams. One should not go beyond 4.5 grams because general practitioners should know that beyond 6 grams, there is a risk of fulminant hepatitis, liver toxicity. So current recommendation are not that we give initially 500 milligram once in a week for 6 weeks, then 250 milligram once in a week for 6 weeks. That protocol itself has been designed just to avoid going beyond the 4.5 grams. So if somebody who is not responding with 4.5 grams, how we can expect that giving bolus doses, high doses, 3 doses, then they are going to make much of the difference. These are some of the.
Thank you. Last question. Dr. Yashaswini, you can answer. Then we'll conclude this session because we have 3 minutes, though we started late. Dr. Vaibhav Mishra has asked, can we use total T4 rather than free T4 to follow up hyperthyroidism as free T4 availability is an issue? Dr. Yashaswini.
Sir, free T4 is advised because total T4, sir, there is interference with other total T4 effect of TBG and effect of albumin can have an effect on the total T4 values. However, sir, if the patient is stable and does not have any comorbidities, then sir, we can go for total T4 if free T4 availability is an issue. If we know that there are no conditions that will interfere with the measuring of total T4.
I personally feel it doesn't matter because lot of laboratories do not have a good free T4 assay. And in the though I have both, but still, whether availability or not, we can interchangeable. So if you have a good T4 assay, not necessary, because why do you expect the thyroid blinding globulin to be abnormal? Pregnancy is a different issue. So in a routine common garden case, whether you have free T4, total T4, it really doesn't matter. If you are a good clinician, go by symptoms, examinations, and go by T4. And you can see because TSH takes longer to normalize compared to T4, you can interchange free T4, total T4. If you are a good clinician, you can make it. It doesn't make really difference. not necessary to insist that you must always do pre-T4. With this, I would like to conclude this session. I would like to thank Dr. Yashaswini for an excellent presentation and all the participants. There are 137 and very good questions. I feel that it is the participant who ask a very good questions who make this masterclass successful. Thank you, all of you. Over to Dr. Nilanjan to carry over to the next one.
Yeah, thank you. That was a very excellently guided by Dr. Prasanna Kumar and Dr. Rajesh Rashford. You were asking why we chose this case. This is nothing rare case. This is a common garden variety case of thyroid-associated orbitopathy, but there were certain learning points in the case. First, as you pointed out, there is no point in going overboard with 60 milligram of Carbamazole and landing the patient up with hypothyroidism, subclinical hypothyroidism that may not have precipitated the orbitopathy, but may have actually aggravated it to some extent. Second, it may be asymmetrical, as you have seen in this patient. And third, yes, rituximab is an experimental therapy. We have used it because we get it in the government services free of cost. We do not yet have teprotumumab, which I think has a better data on regression of exophthalmos, so another biologics that has been used. So that's why we had to settle with rituximab. And of course, cyclosporine would have been another option. So thank you very much. Thanks once again, Dr. Sarita Bajaj, for giving us this opportunity. I think we can ask Dr. Pramila Kalla to proceed with the next part of the program.
Yeah, thanks, Dr. Nilanjan. I think now we have the most interesting, not the most, I should say one of the interesting, because this case was very interesting, a very interesting discussion we had, and a lot of learning points we all got. So now we proceed on to the quiz. So we have no other than Dr. Deep to do the quiz today, and he is the director of Cedar Super Specialty Healthcare, New Delhi. So he has prepared an interesting quiz. So Dr. Deep will tell you the way how you have to answer. So he'll tell you initially, and then that is how everybody has to put their answers so that we don't miss anybody. And at the end, we will be giving the prizes will be given, or the certificates basically. It's the certificate from the Indian Thyroid Society. First, second, and third prize will be announced at the end by our president, Dr. Sarita Bajaj.
Thanks a lot, ma'am. It's a big honor to be part of this clinical learning curve
second case
on different aspects of thyroid. Wonderful case. Thanks to Dr. Nilanjan, sir. We have a quiz here, 8 questions. Most of them are clinical case scenarios. There will be pictorials. So please take time to all the participants. You'll have 60 seconds to go through the clinical presentation scenarios. In most of the cases, you have to maybe give a diagnosis or give a comment, and it's MCQ based. There will be 4 options. So you have to choose the single right answer, the single best possible answer of all the 4 options available. And there are 2 ways of answering. Either you can write it down in a piece of paper for all the 8 question options 1 to 4. You can upload it here, or there's an option, the back end also, I think we'll be getting the options. You can select the options from your screen and put the answers. So can I load the slides, or like how is it going to do it from the back end?
Yes, sir. Good evening, sir. So we have already uploaded the questions on the Zoom platform. So all the participants who want to take part in the quiz, your screen, when we are launching the question, your screen will change to a question, and it will give you 4 options, out of which you can select the best answer that you feel deemed fit, and then submit it. Once that is done, then we can, so how would you want to, do you want to share the correct answer immediately after that?
No, I think let's finish off with all the 8 questions.
Okay.
And let's in the back end that let us analyze the results. Then we can have the second case presentation for the day, and maybe after that, Prasanna Kumar sir, Sarita ma'am, they can give the results for the quiz, and we can have the answers at the end.
Yes, sir. So to all the participants, we will be showing you the case on the screen. We will be first sharing the slides about the case, the images, and then after that, we will be sharing the question on your screen. The first two questions are going to be test questions, just for all of you to get a hang of how the answering is to be done. So I'm launching the first question right now. This is a dummy question. Please note that this is not going to be part of your actual quiz.
Are we all able to see the question?
So I have not yet launched it. Just 1 minute. I will. Now even the panelists will be able to see which question is on. So I'm launching the first question, participants.
We can see only the option. We can't see
Yeah.
the
Yeah, the question is not there, the options are there.
So the question is question 1. Question 1 is the question.
This is the question. This is a test question.
okay, fair enough.
Okay.
So maybe we can just select an option and submit.
You wait 60 seconds.
So right now we will end it at 30 seconds. The actual questions will be for 60 seconds. Now I will be launching the second question, which is also a test question. Five seconds to go. So we have ended these two test questions. Now we will be beginning with the actual questions. I will be sharing the screen now for you to read the case. This is the case.
Yeah, so like we have here two ladies who are pregnant. One is primary and one is a multiparous lady. If you can see, the duration of pregnancy is there. What's common is that both of them are having severe hypothyroidism. So one is at 14 weeks of gestation, the other is at 21 weeks of gestation. The second lady is a 34-year-old lady. It's a precious pregnancy. She was treated for secondary infertility, and this is an IVF pregnancy after a pretty long gap. So the question is from the patient to us is, should we continue this pregnancy or should we terminate? Can we have the 4 options now?
So you have the question and the options in front of you. I'm simultaneously also launching the first question. You will have the question on your screen now. Thirty seconds to go. Ten seconds to go. Question 1 ended. Now we are moving to the next question. I'm launching the second question. Thirty seconds to go. Ten seconds to go. End of question 2. We are moving now to the third question. So would you explain these cases?
Yeah, so like we have 3 kids here. What's common that all the 3 kids, they have goiter. The first one is 5.5 years of age. The second and third kids are 9 and 8 years of age. They've come with short stature. And a few of the other clinical parameters they are mentioned in the slide. Now, these are the set of investigations here. You can see how they're performing in terms of growth, their height standard deviation score, their bone age is there, the thyroid profile, and certain investigations are also there. Radiological investigation, MRI is there. And so what is important is that you have to give the diagnosis. Of course, you'll have 4 options subsequently in the next slide. So give one best possible diagnosis. 3 kids, 3 girls, prepubertal, goiter and short stature common in all 3. And you came across certain biochemical reports, certain radiological investigations, and we have to give a single diagnosis which can unite all 3 of them in the best possible way.
We've launched question 3. You can answer now. Thirty seconds to go. Ten seconds to go. End of question 3. Now we're moving to question 4.
Now, these are certain clinical pictures. They're pretty much evident. It's actually a spotter. You can give the diagnosis directly, but you'll have 4 options in the next slide. You can see certain pictures of the child. Just have to give the diagnosis. A lot of clues are there in the pictures.
Launching question 4 now. For your reference, I'm keeping the slide open. Question 4 is launched. 30 seconds to go. Ten seconds to go. End of question 4. We will now move to the next question. Question 5.
So this is now, you can see here, she's an 18-year-old lady. She had precocious menarche very clearly. You can see the clinical profile of the patient. And there are certain investigations also available here. Certain hormonal reports are also there in the last few lines. You have a scanogram of the CT abdomen of the same lady. So just the need to give the diagnosis. What are we dealing with here? Can we have the options on this page itself? You can launch the options on that clinical slide, on the previous slide.
Yes, launched question 5.
Yeah, but you can show the slides, please. Yeah, thank you.
Thirty seconds to go. Ten seconds to go. End of question 5. We are moving to the next question. Question 6.
Yeah, this is another child. You can see very clear cut one clinical profile of the child, and you have a cut of the MRI of the brain focusing on the pituitary gland. So what's the diagnosis based on the pituitary MRI? Can we have the options here itself?
Yes, question launched. Question 6 has been launched. Seconds to go. Ten seconds to go. Question 6 ended. We are moving to the next question. Question 7.
So this is a girl who came to us with short stature, just an X-ray of the hand. So what's the diagnosis? I know I'm being harsh, but a lot of information is there in the X-ray. You can get the age of the child, for example, and you have the X-ray. So what endocrine diagnosis can you put for this just by seeing the X-ray? So can we have all the 4 options here?
Yes, question 7 launched. 58 seconds to go.
So you have a 12-year-old girl with a hand X-ray showing this. So what fits in best with this X-ray and the 4 options you have? You have to choose the best of the 4 options with the X-ray of the hand of a 12-year-old girl.
Thirty seconds to go. Ten seconds to go. End of question 7. We will now move to the next question. Question 8.
This is the last, a simple question, no clinical case. It's just have to, can we have the options? Because we don't need 60 seconds to answer this. We
Yes,
just have to pick the best option which you think is right. So how much iodine 131 is used for diagnosis for diagnostic thyroid scans? How much units of iodine 131 is used? Not for therapeutic, but for diagnosis purpose.
Ten seconds to go. End of question 8. That brings us to the end of the quiz.
I think now let's hand over the session back to Pramila ma'am. I think we can have the answers with the results after the second case.
Thank
Yeah.
you, Deep. That was nice. That was great. Thank you so
Thanks,
much.
Dr. Deep. It was very interesting and very nice. Quite a lot of mind-boggling questions. So now we go to the last session, but a very interesting session, which will be moderated by Dr. Rajesh Rashford. I invite Dr. Rajesh Rashford to please start the last session of today, and then we will have the results of the quiz at the end. So we'll tell the winners also.
Thank you, Dr. Pramila. I invite Dr. Abhiru to present the case.
Thank you, sir.
Sorry again, once again, for not informing Rajesh. Pramila, we missed out on that because he was not.
We apologize. Yeah.
Right. We start the case. Let's start the case. Abhiru, please present the case.
Thank you, sir. So are my slides visible?
Yes.
Yes, they are visible.
Yes,
I'm audible, sir?
You are audible.
So good evening, everyone. I'm Dr. Abhiru Banerjee, a third-year resident of PM Endocrinology at University Medical College. Today, I'm going to present a very interesting case of inadequately treated congenital hypothyroidism. So it's a story of a 12-year-old Hindu female girl and from Nadia, West Bengal, attended our OPD. And with that background history of delayed developmental milestone, what our mother noticed since 1.5 years of age, cold intolerance, lethargy, and constipation since 1.5 years of age, growth retardation for the same duration, and she was diagnosed to have hypothyroidism at 2 years of age and started on levothyroxine therapy. She had been poorly compliant with the therapy and stopped therapy at 4 years of age. One episode of vaginal bleeding she had at 7 years of age, and therapy was reinitiated and again stopped at 9 years of age. So at the time of presentation, when she attended our OPD, She had another episode of vaginal bleeding 3 months back, and she also had progressive distension of lower abdomen for last 2 months. Her mother told that she didn't, there was no appreciable breast development, pubic hair growth, or increase in height velocity.
Abhirup, just stopping you. What was the age of the patient when patient presented to you? March 2022. What is the age of the patient?
12 years, sir.
So at 12-year patient presented to you. Right.
Yes, sir. Yes, sir. Okay, sir. Should I continue, sir?
Yes, please continue.
So this patient had no history of neonatal jaundice, hoarseness and cry, perinatal essential admission, headache, nausea, vomiting, visual or hearing impairment, no history of edema, recurrent chest infection, seizure, galactorrhea, virilization, or any history suggestive of any intracranial pathology. So patient was born of vaginal delivery at term and cried immediately after birth, and she had a history of poor cholesterol performance. She had no similar kind of history in her family, and her mother attended menarche at 12 years of age. So this is all from history, sir. Should I proceed to the examination?
You have just finished the history.
Yes, sir.
Can I request all those who are listening the case, if there are any questions based on this history? To begin with, Abhirup, at 12 years of age, is a large number of girls will have vaginal bleeding at age of 12 years. So what is unusual in this case as far as vaginal bleeding or start of menstrual cycles are concerned?
Okay, this patient already had one episode of vaginal bleeding at 8 years of age, and followed up by and thereafter she was started on levothyroxine, and menstrual bleeding was stopped. And at 12 years of age, she developed again menstrual bleeding without any appreciable breast development, pubic hair development, or any increase in height velocity. So that is the striking feature, sir.
So basically, the important point to highlight is that there is a sequence of pubertal development.
Yes,
which
sir.
I think, Abhirup, you should tell for the benefit of all listeners that what are the chronology or sequence of pubertal development in girls or females. And whenever there is asynchrony or pubertal development does not follow in a sequence, then we should think of that this is abnormal and something abnormal is going on. So that is why I have asked this question. So can you tell? For the
yes, sir. In girls, first, sir, there is thelarchy associated with increase in height velocity, thereafter puberty, and thereafter menarche.
Right. And what should be the median time period between onset of breast development and menarche?
Sir, 2 to 2.5 years old.
So if we see literature, Abhirup has rightly pointed out, the median time varies from 2.6 years to up to 4.5 years. So any girl which progresses rapidly from development of breast to menarche is not a normal sequence of development, and we should try to find out the reasons that why this is happening. So this is an important historical event which he has tried to highlight it in his presentation. So let's see if there are any questions for this case for you on the basis of history. So I cannot see any question, Abhirup, so you can continue, please.
Okay. Thank you, sir. So on examination, patient's height was 124.5 centimeter, which was less than third centile. Height SDS was minus 3.35, and height age was 7.5 years. Upper segment is to lower segment ratio was 1.14. Patient's weight was 27 kg. Weight percentile was less than third centile, and weight SDS was minus 1.44. BMI was 17.41 kg per meter square, which lies in between 25th to 50th centile. SMA status B2, P1, and absence of axillary here.
Again, Abhirup, I would like to stop you here, please. Just explain these examination findings again to those who are attending this webinar, because they might not be conversant that why we have measured so many measurements. What is the importance of upper segment, lower segment ratio? What is third percentile? Just explain for the benefit of all those who are attending the webinar.
Okay, sir. The patient height was 124.5 centimeter, which is less than third percentile, means it's lower than the 97% of the normal population. And right. Sir, height age was 7.5 years. That means this height patient should have at 7.5 years of age. And the patient upper segment is to lower segment ratio is 1.14 at the age of 12 years. Is supposed to be 0.9 to 1. And because hypothyroidism actually affects the growth of long bones, so this ratio is affected in this patient. Coming to the sir, SMA status, P2 development and P1 development, and sir, pubic hair is absent as there is no thyroxine also plays a role in the pilosebaceous unit, and mild amount of breast development because of sir probably specificity spillover and increased secretion of estradiol. And sir, BMI cut percentile is more or less normal. Is in between sir 25th to 15th centile, and weight age is more than sir the height age.
Right. So there are 3-4 important points that height age is decreased. There is bone age, which is also, I think, decreased. What is the bone age?
Sir, bone age I have shown in the later slides. It is 7 years and 10 months.
So bone age is also reduced
Yes,
in this girl who has already developed menstrual bleeding. Also, the upper segment, lower segment ratio, as Birut has pointed out, suggests of disproportionate short stature. When we see short stature individual, we classify based on all these either a proportionate short stature or disproportionate short stature. So here upper segment, lower segment suggest a disproportionate short stature. Please continue, Guru.
Yes, sir. On systemic examination, the thyroid gland was not palpable, lingual thyroid was absent, skin was dry and coarse, there was nasal depression in the face, macroglycia was absent, patient had vaginal mucosa pink and dull, clitoromegaly was absent. Coming to the GI system examination, one 5 into 3 centimeter probable cystic mass was palpable in the right iliac fossa approaching towards the umbilicus with smooth margin. The lower border of the mass was not palpable. Another similar kind of mass of 7 into 4 centimeter cystic in nature was also palpable in the left iliac fossa and approaching towards the umbilicus. Patient had no ascites. On clinical examination, parvaginal examination was not done. Coming to the other systemic examination, patient didn't allow us to do visual acuity or visual field testing, but other part of the neurological examinations were within normal limit. Only the patient had delayed relaxation of the ankle jerk, cardiovascular and other systemic examinations were within normal limits. So this is all from the examination.
Right. I do not see any question from the examination. Again, there is one question for you. How many hypothyroid patients will have goiter not palpable?
Sir, in congenital hypothyroidism patients, sir, goiter is absent in almost 85% of cases.
Right. And in otherwise other hypothyroid cases in general?
In sir, goiter is around sir present in only 50%, 45 to 50% patients, sir, in adult.
Right. So we are here dealing with a case of congenital hypothyroidism,
yes,
as
sir.
you have learned from the history. So it is not uncommon to find that there is no goiter palpable in such type of patients.
Yes, sir.
Move on, Abhirup. There are no more questions. So we are just waiting if somebody is asking some question. You can continue investigation.
Okay, sir. Thank you, sir. Sir, on biochemical investigations, complete hemogram, renal function test, and liver function test, and lipid profile were within normal limits. Coming to the other part of the biochemical investigation, suggestive of patient was having primary hypothyroidism with a very low FT4 value and rest TSH value. Thyroglobulin was low normal. 8M cortisol was normal. Prolactin was bit high. LH was prepubertal. Plasma estradiol level was 190 picogram per ml. And patient was also done that tumor markers from the outside as advised by one gynecologist. Her CA25 and LDH level were raised, but beta HCG levels were within normal limits. Coming to the radiological investigations, coming to the bone age, patient had a bone age of 7 years of 10 months. To summarize, patient had chronological age of 12 years, height age of 7 years and 5 months, weight age of 9 years, and bone age of 7 years and 10 months. So if one USG, we did a USG and endometrial thickness was 3 millimeter. In the right ovary, one simple unilocular cyst was seen with measuring 6.71 into 5.48 into 7.2 centimeter without any internal vascularity. A similar kind of cyst, which is also unilocular, was seen in the left ovary also. There was no ascites. This is.
Virup, can you please repeat? We have a question. Can you please repeat LH and FSH values again before we move forward?
Yes, FSH was a 9.52 milli international unit per ml. and LH was 0.07 milli international unit per ml.
Right. Move. Please continue.
So we went for a pelvic MRI, and in the pelvic MRI was results were corroborative to the USG findings. In MRI also we can see one cystic lesion of 8 into 7 into 5 centimeter without any septations in right ovary, and similar kind of another cystic lesion was also we can see also in left ovary. And we also went for USG of thyroid gland. Small thyroid tissue was present. Right lobe was measuring around 4 millimeter and left lobe was measuring around 3 millimeter. Isthmus was not seen. We also went for a pituitary MRI, hypothalamic pituitary MRI, and we can see that there was a homogeneously enhancing pituitary with a pressure effect on chiasma, and this is probably due to what we suggested, what we assume that it's probably due to thyrolactotroph hyperplasia, though we cannot go for any formal visual field examination because patient was not very cooperative, and we also didn't go for any automated perimetry also. So this is all from the investigation, sir.
Right. Tell us your final diagnosis.
So my final diagnosis is a partially treated congenital hypothyroidism resulting in short stature, incomplete isosexual precocious puberty, bilateral simple ovarian cyst, and pituitary hyperplasia comprising the optic chiasm.
Right. Thank you, Abhirup. So as you see, he has presented an interesting case involving two important endocrine diseases. One is precocious puberty and hypothyroidism, and here both are linked with each other. So
Yes,
my question to you, Abhirup, for all those who are attending this webinar is that how untreated hypothyroidism will cause an incomplete isosexual precocious puberty, and what do you mean by actually incomplete isosexual precocious puberty? This is the first question. Second question is, what will happen with this pituitary hyperplasia or actually thyrotroph hyperplasia, which is actually behaving like a macroadenoma in a MRI imaging? So these are two questions to you.
Okay, sir. So incomplete means it's a not of central origin, and the pubertal development is not complete and sequential or cannot be predictable. And isosexual means pubertal development is at the concordance of the biological sex of the patient, patient. And precocious means age of onset in female in less than 8 years of age. And sir, in this hypothyroidism, that there is also increase in the TRH, which has some specificity spillover effect on the GnRH receptor at pituitary, which can secrete increased amount of FSH, and this increased amount of TSH also has specificity spillover on FSH receptor on ovary. And these are two reasons for the main reasons for developing the precocious pubertal development in patients with hypothyroidism. Hypothyroidism also reduces the metabolism of the FSH. So these three these factors are actually contributing behind the development of the precocious puberty in this patient. And the second question is untreated hypothyroidism. There is increased secretion of the TRH, and also that will cause the thyrotroph and lactotroph hyperplasia, which can be diffuse or nodular, which can mimic as a pituitary mass. But most of the time, after giving optimal treatment for 3 to 4 months, this mass usually start reducing.
Right. So basically, if we see, TSH shares same alpha chain as with the FSH. There is a difference. These are glycoprotein, they have alpha and beta chain, and because of which, when TSH is present in high concentration, there is a specificity spillover. It interacts with FSH receptor, and such girls can present with incomplete isosexual precocious puberty. If we see literature, all of us as an endocrinologist have seen such type of cases, and such case initially when reported in 1960 is also known as Van Wyk-Grumbeck syndrome.
Yes, sir.
So these type of cases are seen, probably not seen commonly by our practitioner colleagues, but one must be aware that a patient of incompletely treated or untreated severe hypothyroidism can present as isosexual precocious puberty. This is regarding girls. Similarly, if we look into boys, boys can have macroorchidism, that is enlargement of testis in boys with untreated hypothyroidism. We have ourselves many years back published one such case of macroorchidism, which presented to our endocrine OPD and was found to have a severe hypothyroidism. Another important information in this case was Thyrotrope hyperplasia, again, we have published a case where we have also shown that if we treat successfully simply with levothyroxine, there will be complete regression of this pituitary hyperplasia, because sometimes if we are not aware about it, patient may be subjected to unnecessary surgery. And the third very important point, large number of times because of vaginal bleed and because of cysts which are present in the ovaries, these young girls are admitted in OBG wards where workup for a pituitary malignancy is done, and that is why probably in this case an OBG colleague from private practice, they might have done all tumor markers, but unfortunately this is not the case in such type of cases. And when we treat again, make a right diagnosis, treat them with levothyroxine, there is complete reversion of these ovarian cysts also in such type of cases. So these are some important highlights in this case. Let's see if there are some questions for you, Abhirup. I do not see any questions for you, Abhirup. Can I invite my faculty colleagues who are attending the webinar, if they have any questions, comments for this case?
Yeah, right.
Please, madam.
Yeah. Congratulations, Abhiru. Very well presented.
Thank you, ma'am.
Again, very interesting case. But I think as endocrinologists, all of us would have seen such cases. And I'm glad, Rajesh, you raised that point about surgery. When you spoke of pituitary surgery, the tragedy, of course, is always with ovarian surgery. With such big cysts, see, there would be a tendency to remove them. And if you can imagine doing a bilateral oophorectomy in a girl, it would be, I think, the big, big time mess up. Not that it has not happened, I'm sure it has. So I think this is a very important take-home message, that just treating hypothyroidism will reverse all the features, whether it's a mass, whether it's those big ovarian masses, and of course, even the I think the menstruation also, you said, it had stopped, isn't it?
Yes, ma'am. 2 episodes of menstrual bleeding, sir. No.
Yeah, and subsequent height. What is the prognosis regarding the subsequent height?
Sir, ma'am, height potential is actually after replacing the levothyroxine therapy, that catch-up growth must be completed within 3 years. But as we that question's chronological is already 12 years, so it might be there are some we cannot expect a good amount of catch-up growth in this patient, as fondocyte senescence may be present in this patient. But usually, if we initiate therapy very early, at very earlier, then we can expect a complete catch-up growth by 3 years.
So I think the later the diagnosis, the worse the prognosis as far as the height is concerned.
Yes, ma'am.
So it should be as early as possible, because that is one thing that would be compromised. You would not, the full height potential would not be achieved. Rajesh, you were wanting to say something?
No, ma'am, absolutely. Actually, growth is a cumulative phenomena. Any endocrine disorder which is causing short stature has to be picked up early. The late we pick up, the worse will be the height potential. So in this case, since already chronological age is almost 12 years, although there is a delay in age, we do not expect this child to reach to his full potential even by giving a good levothyroxine therapy.
Yeah. Do we have any other questions from any, Pramila or anybody?
Let's me in chat box if there are some questions.
There are some questions, Rajesh.
Yeah. Now they have come up. So there is one question from Dr. Ramiz Raza. Why CA 125 is elevated, Abhirup?
Okay, sir. CA 125 can be elevated in any benign conditions. Ovarian cyst also are reported with elevated CA 125 level, and thyroid hormone also decreases the clearance of the tumor markers. That might be a cause of elevation in CA 125.
Right. So another question from Anuj. Do increased TRH, increased prolactin, or it has action on LH and FSH? So basically, he's trying to ask you the mechanistic aspect, which you have tried to explain. So he's asking whether increased TRH causes increased prolactin or it has action on LH or FSH.
So it causes both. It actually acts on that GnRH receptor on pituitary gonadotropes and elevates the FSH level. And it also causes lactotroph hyperplasia, which causes increased amount of prolactin. Now coming to the LH level, which is prepubertal in the patients with primary hypothyroidism with isosexual precocious puberty, because of probably the postulation is hyperprolactinemia mediated suppression of LH secretion. So that's why FSH, we can expect an elevation in FSH level, we can expect an elevation in prolactin level, but LH will be prepubertal.
Right. So I think now it is pretty clear. Abhirup has tried to further simplify the mechanism of action of various hormonal interactions, axis, which are happening in untreated hypothyroidism. Another question has come up, Abhirup. What are the cause of cyst in ovary in this case?
So probably this cyst is because of uncontrolled FSH or increased TSH mediated stimulation of FSH receptor. That uncontrolled stimulation which actually causes the follicular development and follicular cyst, development of follicular cyst.
Actually, there are receptors for FSH present over the granulosa cell, and it is a granulosa cell where there are cysts which are present. So uncontrolled stimulation will cause enlargement of cyst. One important point to remember between isosexual complete puberty and incomplete puberty is cyst can be seen even in true precocious puberty, but there the size of cyst is always less than 9 millimeter. In contrast, in patients who have pseudo precocious puberty, like this case, there the size of the cyst are usually more than 9 millimeter. And that is why they present as a tumor-like or mass in the abdomen. But important point to remember is that if we treat hypothyroidism successfully, there will be successful regression of these cysts in majority of these individuals. Another question has come up, probably this is the last question. As bone age is delayed, to what extent can growth improve with treatment of hypothyroidism? Although we have answered this question, but Abhirup, again, I will ask you to answer this question for the benefit.
Actually, growth hormone theoretically should be stopped at the onset of the hypothyroidism, sir. Bone age should be stopped there.
No, he has not asked about growth hormone. Abhirup, please, he has not asked about growth hormone. He has asked, as bone age is delayed, so can what extent growth will improve with treatment of hypothyroidism?
Okay, sir. If the diagnosis is at earlier age, then we can expect almost normal height, adult height. And if diagnosis at the later chronological age, then we can expect a compromised adult height by -1 STS, 1 to 1.2 STS.
So we have already answered that earlier the diagnosis is made, better for the patient because growth is a cumulative phenomena. Already the diagnosis is made quite at a late stage. So although bone age is delayed, we expect some improvement in height of this girl with the treatment, but full height potential is unlikely to be achieved in this girl. So I do not see now any more questions. So I thank Abhirup for nicely presenting an interesting case of untreated or inadequately or inappropriately treated congenital hypothyroidism, where severe hypothyroidism has resulted in a precocious puberty, that's a pseudo-precocious puberty, and then a successful diagnosis actually has helped this girl. With these few remarks, now I will invite Professor Nilanjan to give his comments for the case before we hand over to Pramila and to our President, Dr. Sarita Bajaj.
Thank you, Abhirup, and thank you, Dr. Rajput, for wonderfully guiding him. Yes, our aim of presenting this case was that even with the endocrinologists, the consequences of untreated primary hypothyroidism may be missed. And the gynecologist who was treating her was thinking of an ovarian malignancy and she ran the risk of undergoing unnecessary surgical procedures. That should also be kept in mind, and our gynecologist colleagues should be sensitized to that. And of course, this case shows the importance of knowing, that is to the endocrinologist, what feedback adenoma is all about. Again, that probably will not require any definitive treatment other than good management of the hypothyroidism. And third point is that hypothyroidism can lead to precocious pseudopuberty and at times even can cause result in a generic dependent sexual precocity also, which was not there in this case. That can also rarely happen, that we have to keep in mind. So I think this is an instructive case, not only for the endocrinologists, but for our gynecologist colleagues or even to the neurosurgeons, because such patients can land up to a neurosurgeon also with a so-called pituitary tumor. Thank you for giving us the opportunity to present our cases from our department in this ITS program. And I once again thank Professor Sarita Bajaj and the team for giving us this opportunity.
Thank you.
Yeah, thanks, Dr. Nilanjan, and thanks, everyone. And we had a very nice discussion today, but now it's time for knowing the answers to the quiz questions, and then we will have the results, I think. So Dr. Deep will tell us the answers now.
Yeah, thank you, Nilanjan. Thank you very much. Thank you. I think the success of the meeting is due entirely to you and your, of course, your department, your residents. Thank you. Thank you so much. Yes, over to Deep.
Thank you so much, ma'am. So I think we are running late. I'll just brush up each of the cases.
Yeah.
There were 8 cases. The first were 2 ladies with pregnancy. One was a precious pregnancy after IVF, a 34-year-old lady, and the other was a primary gravida, 22-year-old lady. Both had severe uncontrolled primary hypothyroidism, TSH of 61 and 42. The question the patients always ask us, should we terminate or not? There were options. The 4 options were, we can terminate if it is less than 12 weeks of gestation. The second option was we should terminate if it is less than 20 weeks of gestation. The third was we should terminate if it is less than 24 weeks of gestation. And the last was, there is no role of termination of pregnancy, irrespective of severity of hypothyroidism. The answer is option 4, very clear. That's a very important take-home message which should go, irrespective of severity of hypothyroidism. No pregnancy should be terminated. A lot of wrong things just happen. There's a lot of lack of awareness among the treating doctors, gynecologists, physicians. The Endocrine Society of India in their guideline clearly says so. The American Thyroid Association in the guidelines clearly says so, that thyroid or thyroid disorders or hypothyroidism can never be and is not an indication for termination of pregnancy. It's very clear. The second question, question 2, was related to the first question. So what about children who are born to mothers with uncontrolled hypothyroidism in pregnancy? What's the mean change in their IQ scores? The option was, 1 was minus 25 scores. Option 2 was minus 15 IQ score. The option 3 was minus 5. And the option 4 was a plus 5. Well, the answer here is minus 5 points IQ scores. A lot of data is there. There's the New Zealand data, there's the Australian data, there's the Scandinavian data, where they have seen in women who had hypothyroidism in pregnancy and those who were euthyroid in pregnancy, the matched controls. The kids, the IQ was measured at 4 to 6 years of age post-delivery, and they found hardly 5-point IQ score difference. In fact, in the control group, the mean IQ was around 107, 108, and in the women who had hypothyroidism, those kids had IQ score average around 102. So the difference was 5, but if you look at the absolute values, anything more than 100, we call it super intelligent. So what are we talking of? Are we talking of less super intelligent child with a more super intelligent child? So in the real life scenario, it really doesn't make a difference. No pregnancy should be terminated. There's a lot of misconception in our society. Patients are fearful that their kids are going to have low IQ. It doesn't happen like that in the real world scenario. Now the first set of pictorial questions, we had 3 girls who had short stature, who had goiter. What unified them? But if you see here, we suspect hypothyroid, short, goiter, but then they had certain features which were not matching with hypothyroid, like they had tachycardia to start with. Some of them had hyperkinetic features also. If you look at the thyroid hormone profile carefully, I mean, if you had looked, the TSH was not high. They had high T3, high T4, and the TSH was not low for the high T3, T4. So what are we dealing with? So it can be either a thyroid hormone resistance, or it can be a TSH producing pituitary tumors. The MRI report was provided in all the three kids. The MRI was normal. What's important is that if you look at their levels, we had given the levels of ferritin and albumin. In a true hyperthyroid state, it increases the hepatic turnover. So the globulin level goes up, the ferritin level goes up, the SHBG levels goes up. But in all the three girls, the ferritin and SHBG level had not increased. So this is a good surrogate measure of hepatic thyroid hormone resistance. Very cheap investigation by which we can find out or document. In true hyperthyroid patients, always the ferritin and SHBG would go up. A goal. So basically, these were three girls with thyroid hormone resistance. The gold standard diagnosis is to look for thyroid receptor beta mutation, which is found in nearly 96% of all these patients. Hardly 2 to 4% will have thyroid receptor alpha mutations. So unfortunately, these tests are not routinely available in clinical practice in our country, but we can still make a diagnosis based on their hormonal profile, and certain other biochemical investigations like ferritin or SHBG levels can help us in establishing hepatic thyroid hormone resistance in the setting of raised T3 and T4 levels. The fourth was a picture of a young child who had a swelling in front of the neck, and we have a picture of the open mouth. You can see a swelling behind the uvula. Just at the base of the tongue, there's an arrow there showing a swelling just at the base of the tongue, just in front of uvula, if you can see here. And a picture of thyroid scan, a sodium per technique scan was provided, which showed increased uptake in that region of abnormal swelling at the base of the tongue. This is nothing but a lingual thyroid. Very clear-cut case of lingual thyroid, can be spotted in the exams also. The fifth question was that of a girl whose chronological age was 18 years, but if you look at her faces, she definitely doesn't look 18. She looks maybe 9 or 10 years maximum. She had a pot belly abdomen. If you can see carefully, she had a milky discharge from the nipples. She had galactoria. She had precocious menarche at 7.5 years of age. She was in fact referred from gynecology for fitness for surgery because they found a huge ovarian tumor. You can see a CT scan showing a nice multi-loculated huge enlargement of the ovaries. So what's important here is that this was because of uncontrolled hypothyroidism. So the TSH level was deliberately not mentioned in the set of investigations here. She had a TSH of more than 100. She was unfortunately a young lady who had untreated primary hypothyroidism for many, many years. And that the high levels of TSH cross reacts with the LH and FSH receptors at the level of ovaries, and it causes huge enlargement of ovaries. What we call is the von Wig-Grumbach syndrome. This is clear case of von Wig-Grumbach syndrome or pseudo-precocious puberty. Question 6 again is a similar patient, a similar pseudo-precocious puberty as another variant of von Wig-Grumbach syndrome. But the question was highlighting here, showing an image of the MRI pituitary. So it was clearly showing the feedback hyperplasia of the pituitary gland. Just now in the last case, it was beautifully highlighted by Professor Nilanjan from his case from the department. So a clear-cut image of pituitary hyperplasia, diffuse enlargement of the pituitary and the stalk was seen in the image of the pituitary. So that was the answer we're looking for. We're looking for feedback enlargement of pituitary. Now question 7 was a simple X-ray of the hand. It had only 3 carpal bones, but if you look at below, the age was mentioned 12 years. There's a very big discordance between the bone age and chronological age. And again, very leading options were given. You just had to choose the right option. What was the cause for the short stature? So Turner syndrome was one of the options. Growth hormone deficiency was the second option. Celiac was the third. And fourth was primary hypothyroidism. In Turner's and growth hormone deficiency, typically the bone age is usually delayed by 1 to 2 years. So never such a huge discordance of bone age of around say 3 years, and we have a chronological age of 12 years. Such drastic huge gap between bone age and chronological age is seen classically in untreated, prolonged, long-standing primary hypothyroidism. Dr. Rashford highlighted to us how these kids, they end up catching some amount of the growth, but they unfortunately never end up having the normal height potential had they been treated at the time of diagnosis of hypothyroidism. The last question, it was just not a case, just a point-based question. So we all know that we use what amount of iodine 131 is used for treating of Graves' disease in thyroid cancers. It ranges from few to many millicuries, but when we talk of diagnostic thyroid scans, which we do for screening to differentiate thyroiditis from Graves' disease, the dose used is 40 microcurie. So the answer was option 2, 40 microcurie. And I think with this, I'm handing over the stage back to Dr. Kalra. Over to you, ma'am.
Thank you.
Thanks, Dr. Deep. Yeah. So now I request ma'am to announce the name of the winners for the quiz today.
Yeah, so we're really running late. Thank you, Deep, for being with us. So we have 6 winners who have all answered 7, who've got a score of 7. So we'll decide later as to how to go about that. And I think the tech team will contact them. First is Dr. Bharti, then Dr. Debaditya, Dr. Sri Devi, and there's one name, Dr. H.A., that's all we have. Dr. Pankaj Singhania and Dr. Pias. So we'll get back to you and you'll have your certificates as well. Thank you all. Thank you very much. Thank you for joining us. And thank you, Pramila. Thank you, Arun. Dr. Nilanjan, Dr. Yashasvi, Abhiroop, Dr. Rajesh Rajput, and of course, our patrons, Dr. R. Vijay Kumar and Dr. Prasanna Kumar. And I think somebody who's been binding the whole thing together, our reporter, Dr. Lohit. Thank you. Thank you very much. This is going to be an event, and I think we're just showing you when is the next webinar, in which we'll be having a duologue on thyroid nodules and a little talk about surgery, thyroid nodule surgery, as well as a quiz. Dr. Gagan Priya will be organizing the quiz. The duologue will be Dr. Satinath Mukhopadhyay and Dr. Vagish Iyer. And Dr. Amit Agarwal will be giving us a perspective about thyroid surgery. Thank you. Thank you very much.
Thank you very much. Good night.
Good night. Thank
you. Good night.
Pramila.
Audience also.